This is Raphael Landovitz from University of California, Los Angeles, and it's today at the Latina Forum here in Salvador, Brazil. I provided an update on long-acting injectable cabotegravir for HIV pre-exposure prophylaxis, and the key points that it's important to know about this new HIV prevention strategy is that there are two large phase 3 registrational trials that contributed to the regulatory approvals of this agent. It is approved now in the United States, here in Brazil, although not yet implemented in Brazil, Peru as of today, South Africa, Botswana, Malawi, and Zimbabwe, as well as Australia, and also new in European Union. So we look forward to global implementation of this strategy. The efficacy results from the two trials suggest that compared to daily oral TDF-FTC PrEP, cabotegravir was superior to that intervention. It was 2/3 fewer HIV infections in cisgender men and transgender women that were studied compared to daily oral TDF-FTC, and 90% fewer HIV infections for cisgender women compared to daily oral TDF-FTC. Both extraordinary results. Also really exciting is that the safety profile was very good. The most commonly reported side effect was injection site reactions, which were pain or tenderness at the site of intramuscular injection, and there really was nothing else that came as a safety signal. Importantly, it seems like it's safe and well tolerated in pregnancy as well, and we are still collecting data in the HPTN-084 study with regard to safety in pregnant women. So we look forward to more information for pregnant and breastfeeding women in that regard. Then I spent a long time talking about the rare but important PrEP failures on cabotegravir and the importance really ruling out acute or primary HIV infection before starting somebody on any PrEP, but cab PrEP in particular, because once you start somebody on cab PrEP, it becomes very difficult to diagnose the new HIV infection. And that's true regardless of when the new infection occurs, and that's because long-acting cabotegravir is such a potent and prolonged mechanism of action that the PrEP failure actually presents very differently from acute or primary HIV infection without PrEP. The viral load is low, right at the limit of detection, so antibody and antigen detection is also delayed. So conventional assays for detection of PrEP failure are not as sensitive with long-acting PrEP agents, and the consequences of that, an undetected HIV infection persisting in the presence of cabotegravir, is cabotegravir resistance, which will then make that HIV infection much harder to treat. So that's a very important potential consequence, cab PrEP failure in certain circumstances. The diagnosis of HIV infection before starting PrEP is one of those really important circumstances. The other is PrEP failure during an oral lead-in, which is now optional with regulatory approvals. That's the other context in which resistance can happen. And then with failure with on-time injections, which also is a rare event, but when it does happen, it can lead to resistance. Interestingly, although we worried a lot about infections that occurred during the prolonged pharmacologic tail of this long-acting agent, we did not see resistance in that clinical context. So 6 months after the last injection, if infection is acquired, there does not appear to be either delays in detection or resistance consequences. So that is all really important information. The final points that I made is that this is a clinically silent seroconversion, different from acute or primary HIV infection that we're normally used to thinking about, which is very much like a mononucleosis syndrome. This is clinically silent. And finally, a lot of people ask me if both agents are available because the study results showed superiority for cabotegravir, does that mean that I should prescribe cabotegravir for all my patients and switch everyone who is on oral PrEP already to injectable PrEP? And my answer is no. The best PrEP for any given patient is one that they will agree to start, that they will be able to adhere to, and that they will persist with. And if that's pills, there is no reason you have to use the injection. If they struggle with taking pills regularly, then I think the injection is a really powerful option, but there is no reason to switch everyone. And of course, cost remains a large issue, and we really need advocacy from both potential consumers of PrEP, from the community, and from providers for both generic and inexpensive formulations of these powerful new PrEP agents, but also advances in HIV diagnostics. We can have inexpensive point-of-care sensitive diagnostics that will help us find these breakthrough infections earlier than is currently possible with rapid and even current instrument-based laboratory assays, so that we can potentially find these agents before before there's resistance, because we don't want it to complement future treatment options. I think a lot of these considerations will not be unique to cabotegravir PrEP and will be applicable to future long-acting PrEP agents as well. So I think these principles are really important even before CAB is rolled out, and we look forward to having other long-acting oral and injectable and other agents that are delivered by other mechanisms to be able to add to our list of agents to use to prevent HIV infection. Thank you very much.